No, all bacteriological tests were negative, as well as sputum and bronchial alveolar lavage.
You didn't write.
And also the cytology of the bronchial alveolar lavage. What was the cytology?
The result was written like that. Exclusion means Doppler
What's the result written? A number of cells, a percentage of macrophages, a percentage of lymphocytes, a percentage of neutrophils. Otherwise it's a bronchial aspirate, it's not a bronchial alveolar lavage.
Subpopulation lymphocyte.
So I think the last point is if you want to diagnose sarcoidosis from a bronchial alveolar lavage, you need to have certain quality controls and elements of the report. And we've done that discussion last year when we've seen the report from Germany, how it looks, and we don't report, we don't report like this. Yeah? So you need to be very specific how many epithelial cells, how many lymphocytes, how many macrophages, and then that how many of the different lymphocytes, and that will give you a possibility of sarcoidosis. It doesn't give you the diagnosis. You need histology with cultures, and even those are still not definite.
But this kind of result displayed like this suggests it's not a bronchial alveolar lavage, but a bronchial aspirate.
Yeah,
Which it might be useful for
microbiology.
plastic cytology.
And get into that.
Let's see next.
There were no modifications of the epithelium for biopsy.
Yes, but in sarcoidosis, for example, we take several biopsies from the bronchial.
Yeah, that's another learning point. So if you want to diagnose sarcoidosis, you can do a mucosal biopsy, even if you don't see endobronchial visible lesions. There is, I think, the yield is very high because the small granulomas are disseminated everywhere in the lung. So it's something which should be done.
Obviously, and the open biopsy with the thoracotomy and segmentectomy. We opted for the latter because our surgeons are quite proficient at this, and we also located one nodule which was very close to the pleural. It was when the surgeon described it as exactly outside our. So the result was the following: necrotic material surrounded by a rim of histiocytes with fibro-inflammatory tissue, and with the magnification, the clear border between necrotic and healthy tissue, as well as the macroscopic aspect, which was a white fiber tissue. So, as treatment course, we did not initiate any antibiotics or pulmonary treatment. We sent him to the rheumatologist.
So what was the conclusion of the biopsy?
The conclusion of the biopsy, polyrheumatoid nodules.
Fibro-inflammatory.
He started a new course of rheumatoid treatment, anti-rheumatic treatment, and we also consider the following complications in his case. He could have had, if he would have left it completely alone, the nodules would have become super infected. He could have suffered infections and other complications. So the prognosis, the nodules could have had three evolutionary paths. Cavitation, which was the case, increase in size, or resolve spontaneously. After 3 days is the CT taken 3 months after reinitiating the rheumatoid treatment, and as you can see there are no more, the nodules with the mastoma-like aspect were decreased in size significantly, and speculated nodule disappeared completely. So the particularities of the case are the fact that the patient was in perfect condition. he had an asymptomatic period of rheumatoid arthritis, and this was a very non-specific, a very specific but
before coming to us. Overall, the morbidity and mortality of rheumatoid arthritis associated with lung diseases are high, and really it was unusual because he only had nodules, no other complications, no other manifestations of rheumatoid arthritis associated lung disease.
Questions?
Yes. What would have been the diagnostic yield of a CT-guided needle aspiration in this case?
Diagnostic yield depends on the location and the size of the nodule. It will be the same with any other nodule which is like this, and it will be high because it's in the periphery and the surgeons got it, the chest radiologist would have got that. So yeah, but they didn't have it, so that's why they didn't do it.
Normal. He was
Normal.
he was under control.
I also had this kind of patient, approximately identical. Diagnosed rheumatoid arthritis, long-term treated, asymptomatic at the moment of presentation. I performed a lung biopsy because this was also it was a confirmed that it's a rheumatoid nodule, and after that I was asking myself, was it
Worse?
worse to do a surgery on a patient, or would it have been a patient with established diagnosis of rheumatoid arthritis? It's better to follow up for 3 months, and because if it's a cancer, anyway you cannot operate because
Yeah,
it's already with
metastatic cancer.
metastasis. So
What
it's
do
not
you-
a loser.
Well, I think
No, it's for the Eurovision.
okay. I think what you just said about doing a CT-guided biopsy, I disagree with, because I think sometimes if you're asking if you've got malignancy and there's lots of nodules, you can always argue that you've just biopsied the wrong area, and you get a small bit of inflammatory tissue, which is consistent with rheumatoid nodule, but you can't convincingly say this isn't malignancy if you are suspicious, or so it depends on what your pre-test opinion is. So if you think this guy's got rheumatoid nodules and you want to confirm that, I think a CT-guided biopsy is okay. If you think he's got malignancy and you want to rule out malignancy, then I think if you get a CT-guided biopsy and it shows malignancy, fine. But if it just shows inflammatory change, I'd have the doubt in my mind that you've just biopsied a very small area, which was inflammatory, and right next to it is malignancy. I don't know, so I think that there are limitations. So surgery is the best, but it's more invasive. Whereas I think sometimes the CT-guided biopsies, you can get false negatives. I'll probably do if I was going to biopsy, I'd do a PET first, and then I'd do a CT-guided biopsy of the hottest area.
That's absolutely true. I mean, important, and that's what we discussed before. So if you think this is rheumatoid, then thank you very much. I think my learning point is, and we had some case presentations with nodules, and none of them was a malignant nodule, as far as I remember. But this is an important point. So if you look at the study with screening, so lung cancer screening, from 20 nodules you pick up at screening, only 1 is malignant, 19 or so are not malignant. So going and stressing the patient or doing the procedure to take the nodule out because you think it's malignant is probably not the immediate statistical or the mathematical right thing to do. And that's why I do agree. I do think that applying an algorithm with risk assessment is probably better than jumping and doing surgery. Surgery is easy, you know, you take the lung out and you know what it is. But do you agree? I mean, you know, the number of nodules which are benign is actually higher than the numbers. I mean, it's much higher than the pick-up rate of lung screening. And this is the problem. We'll have to screen the patients from now on, and we have to have a plan what to do with the incidental findings of all these nodules. Any questions? Anything no, Corazon. You want to say anything?
Meritat biopsia la cazul ăsta? Eu l-aș fi trimis la reumatolog.
Aproape clar că era reumatolog.
Bă,
Poliartrita.
Da, și serology and
But the diagnosis was already established. You could have had positive
yeah, and
serology.
you could monitor the case very well.
Evolution.
Anyway.
Good. We'll move on now. Yes, so we have Neil who will present what you can do from the bronchoscopic point of view in terms of investigations.
Da?
I've got a message from Claudio who is watching online and he said we need to speak in the microphone. So, hello, Claudio. Mulțumesc foarte mult colegilor care au pregătit cazurile. Cred că e efortul meritat și important discuția în jurul cazurilor. Deci mulțumim foarte mult că ați venit și ați pregătit cazurile. Da, administrativ vorbind, după prezentarea lui Nil, pauză de cafea, după aceea ne împărțim în două grupuri în sala de aici, partea de sală care rămâne pentru prezentare. Irina va discuta despre tehnica scrierii unui articol și foarte este un set de prezentări care l-am făcut împreună și vă spun că e foarte interesant și foarte util. Cine a fost ieri la atelierul de ecografii poate să treacă în spate să mai practicăm, să mai facem câteva ecografii pe voluntare care îi avem. Deci,
dorește,
și
la basic, la mine jos.
Doamna profesor din nou are un ecograf jos. Pentru basic este un articol publicat în ultimul număr din pneumologia cu elementele de bază, care va fi articolul de căpătăi, cel mai bun articol scris în ultimii...
Am adus folii pentru cei care nu au revista. Am adus...
Da. Deci articolul este jos.
Ați primit revista? Cine este abonat?
Ați primit revista? Da.
Eu nu, dar este oricum online. Deci pe site-ul
este și online și
găsiți toate articolele în PDF.
Aici cu pălăria de la revistă, cu prezența lui Irina, care e editorul revistei, deci încercăm să încurajăm cât mai mult, în special medicii tineri, să prezinte, să publice cazurile interesante, seriile retrospective pe care le faceți, pe care noi în Anglia le numim audit, de fapt, da? Deci să vedem cum funcționează un serviciu. Ca să vedem cum funcționează un serviciu, analizăm câteva cazuri și vedem care sunt rezultate. Deci așa numitele studii retrospective care erau înainte, dacă aveți studii prospective, foarte important, pentru că acelea sunt studiile care sunt citabile și, din nou, orice articol educațional din partea seniorilor din pneumologie. Neil, thank you very much.
No, no problems.
You need to speak in the microphone, smile to the camera. The world is watching.
Well, I'm afraid. So, Jude, is this, am I being a bit slow here? Just quite straightforward.
Secret was only
Ah, well done. And the point is the red one, isn't it?
pointer is the right one.
Perfect, thank you. Hi, good morning. So firstly, thank you for, thank you, Judah, for inviting me to come and speak here. I originally came to the very first meeting in 2009, and I think it's a real positive that all of you, along with Judah, have kept this meeting going, and it just seems to go from strength to strength, so that's absolutely excellent. So Judah contacted me, I don't know, 2 or 3 months ago, and said, Neil, you do interventional bronchoscopy with endobronchial stenting. Could you come and do a presentation on that? And I said, fine, no problems. I've got it already prepared. And then a couple of weeks later, he contacted me with a new title. And then more recently, he's changed my title again. So I've learned never trust Tudors on the take-home messages. So he's asked me to talk about bronchoscopy and how we can use that in managing pulmonary nodules. There'll be some basics in it, and there'll be some stuff which is, looking into the future. So first, I suppose, how many people in the room regularly perform bronchoscopies, whether it's training, whether they're registrars, or so probably about 50%, maybe a bit less. Yeah. Okay. Fine. So we're looking really at, and I'm sure you've heard this lots over the yesterday as well, what a solitary pulmonary nodule is. We've discussed a couple of cases, and by the definition, in the middle case, the second case, we're actually talking about a pulmonary mass by the end of it. So a pulmonary nodule is less than 3 centimetres, and it's surrounded by lung parenchyma. It's a white lesion found on CT, and it shouldn't have atelectasis, it shouldn't have consolidation around it. And then subsolid, solid, ground glass, these are all coming into play now. The workup when investigating them is either looking at previous imaging, serial imaging if we have that. We've talked a bit about PET already, and then the probability of malignancy. So when do we need to investigate? When can we just sit and watch? And that's really quite a difficult thing to get to the bottom of. And how do we find these? Well, I think in my practice, the minority of patients are the ones who come in with cough, hemoptysis, weight loss. The vast majority of these group, so they've had a CT for colorectal malignancy follow-up and someone's found a nodule, or they've had a CTPA for pulmonary embolism, someone's found a nodule, or half the time people don't even know why they've done a CT, they've found a nodule and send it your way. So the National Lung screening trial in the States reported in quite a variable amount, but in incidental findings of up to 50%, but it's much less because those were selected populations. So these are the guidelines any chest physician has sellotaped to their office door. The Fleischner guidelines, well, that was out in 2005. They've subsequently released then their ground glass or their subsolid guidance. The American College of Chest Physicians guidelines in 2013, and then Tudor's already spoken about the BTS guidelines, which are it's a massive document, so it's very complex, which is a slight irritation. And these are the Fleischner guidelines. So we're talking in the first case, you can look at your nodule size in a low risk patient and just follow them up. And we talked about whether we should do the scan at 2 months, 3 months, 4 months, and I think it's clear the timing distances we should use. So this is something that's been around for 10 years now. It's 2005. So this is something from the American chest physicians, American College of Chest Physicians, And these are the patients who have the slightly larger nodules. So they say if they're less than 8 millimetres, you go down the Fleischner guidelines. And these bigger ones, between 8 and 30, are what we're looking at here. And the way they phase it, putting surgery up front, which I think also seems to be the trend here, you assess whether high surgical risk or low. And then this is the difficulty we're faced with, assess your clinical probability. And you've got to get an exact percentage somehow, between 5 and 65, greater than 65. And then whether you go, if it's low, you just go to CT surveillance. Low to moderate, you need to think about getting tissue with or PET. And high, again, standardisation with PET. This other group is something that we don't manage very well. The people who are high surgical risk, how do we get tissue on those? And I think, as we all know, most of our patients have multiple comorbidities. As we know, smoking is a risk factor for these nodules, and they often have airways disease or other problems concurrently. So these are the sort of groups we're looking at as to how we can get tissue on those in less invasive ways. I'm going to skip that. So who should we investigate? As we said previously, these patients are often completely asymptomatic, and we need our pre-assessment again. Have they got history of cancer? Are they cancer from other sites? And so we're going to use this combination of clinical, radiological features to get our pre-test probability of this being cancer. And our goal really is to get the least number of invasive procedures, the least expensive way, and the fastest path for these patients, to try and upstage them, so diagnose them in stage 1, to give them potentially curative treatments. So again, this is from the chest guidance, the American College of Chest Physicians. Always looking back at the old imaging. If that's helpful, brilliant. You can just stop there. If it's been there for 2 years or so, just leave it. And then the CT scan, looking at the solid or subsolid. And again, these are thin sections, so they're much more detailed than say, the volumetric scans we used to do a while ago. So we get much better imaging, and you get much more comparative findings. So subsolid, we're going to move over, and we're going to go straight to these ones, the solid nodules. Again, you need your pre-test probability, and these are the patients in the intermediate who we need to get histology on in these two groups here as to the ones we're looking at. The Fleischner guidelines, as you mentioned, are quite clearly demarcated for the smaller nodules. So this is very similar to, I think, almost identical to our first case we had. So I just made this up. A 50-year-old man who's a never smoker with no past medical history has a right lower lobe nodule of 14 millimetres, smooth in outline. So we need to, from those facts, we need to decide whether we're going to intervene, whether we're just going to do a CT scan. And so I think Tudor showed yesterday this risk calculator. So that's the web link at the top. And you pop it in, non-smoker, 50, no previous cancer, 40 millimetres. We haven't had a PET yet, and we said it's smooth and it's lower lobe. So his risk of malignancy is 4%, or 4.4. So using that simple calculator, we would probably go down CT surveillance route. Okay, so we can leave him alone. But if you just flick one of these things, so if we move this to upper lobe now, from lower lobe, he's suddenly into 9%. So you're then in the realms of, well, we need to take this more seriously. You do your PET, and certainly if it's intense uptake, it's suddenly almost, very worrying. So small factors, as your history goes on, your probability changes. So for example, someone you may have thought, well, we'll just sit on him, he's fine. For some reason he's had another scan or he's had a PET. Suddenly your probability can change. So in these patients we're looking to investigate, the procedures we're looking at are something that we can increase the yield of diagnosis, so we can get earlier diagnosis. They need to be relatively easy to do, so we don't want to be trying to get techniques that are so subspecialised. that chest physicians cannot do it. Scalable and financially sound, so they're basically similar. And also your safety profile needs to be kosher. And these are the options that are out there at the moment. So we've talked a bit about, we heard about CT-guided biopsies, CT-guided transthoracic biopsies. And as a rule of thumb, my radiologist always tells me that every layer of pleura you go through with a needle gives you a 5% risk of a pneumothorax. So you always go through one. Then you'll go, if you're going across a fissure, you're going to go through 2 more. So that's 15%. So there's a role for it, but I think that's one thing we should also bear in mind. Bronchoscopy with guidance. Surgical resection, obviously, we've talked about again this morning. Radial EBUS or EBUS mini probe. And then the navigation bronchoscopies and also ultra-thin bronchoscope, which we will talk about. So this is just the things that we're going to think about before we press on. Where is the lesion? Is it very peripheral, making a CT biopsy more preferable? Is it central, making routine bronchoscopy probably more preferable? And then you have that middle ground, which is central, but it's invisible, or routine bronchoscope. Then obviously other things, patient choice, safety and efficacy, pulmonary function testing, etc. And this is what we used to do, and this is the well-trodden path for lung biopsy. So simple bronchoscopy, and then sort of C-arm from radiology, fluoroscopy, imaging the lesion here, biopsy forceps going in, and the yields were improved with the fluoroscopy, but for these peripheral lesions, in most of the studies, the yields never really got near 50%. They're increased from about 20-30% to about 40 or so percent. And the difficulty you have is obviously you need to have a C-arm, so you need to have either a very helpful radiology department, or you need to have your own radiology C-arm in being projected in 2 dimensions. So you don't know whether you're behind the lesion essentially with this, or in the lesion, or so it's quite difficult to navigate. It's also quite difficult to see smaller lesions. So this is really come and gone, and people don't really do that anymore. The linear EBUS, I'm not going to talk much about that, but this is a well-defined, well-recognised way of staging lung cancer with your central lymph nodes. And you've done a bit of ultrasounding earlier in the workshops as well, so it's exactly the same principle. It's quite difficult to drive when you start because you've got an angled scope, so actually just getting through the cords into the trachea is a bit more challenging than a straight scope. And this is your ultrasound probe on the side here, and this is your aspirate needle coming through. So this is just in diagram, so essentially what you're doing, there's the trachea wall, there's a balloon which is inflated with saline, so you can ultrasound across, and there's your lymph node. And in all the diagrams, things always line up perfectly, and the needle goes straight into the node. And that's well documented. The evidence base behind this is significant, and this is just a diagram of the images you actually see. So this is what is perhaps more useful in the pulmonary nodules and the peripheral. And this is the radial EBUS or EBUS mini probe. The terms are relatively interchangeable. This is it in section, and this is how small it is. That's just through a standard bronchoscope. And you have an inflatable balloon which you can inflate with saline, and you have your ultrasound probe inside that. These are the pictures you get. So in the centre is your airway, and this is the pulmonary mass that you can see interfering with the ultrasound. So very briefly, the physics is the radial is what we're talking about now. So you get a 360-degree picture. It's a higher frequency, so it gives you slightly better image quality. They say about 4 to 5. I'm not sure if you can quite get that deep, but that's what they claim. But at present, you don't have the ability to do TBNA through it with the direct guidance with the ultrasound, and you can't do Doppler, whereas you can, and that's what the linear's aimed at. Obviously, this is a bigger scope. You can't get peripherally with that. So this is essentially what we do. Bronchoscope comes down. The mini probe goes out. You ultrasound across the lesion. You see the lesion here, and then you biopsy it. So I think, yeah. So we've got a little video of it here. These aren't my images. There we go. So this is just coming down with the scope, obviously, into the basal segments, and that's advancing the probe, and it'll move on to the ultrasound picture shortly as you're getting in contact with the probe, with the wall. So this is just relatively normal. You've got the airway in the centre, and just moving down the airway wall. There we go. We're getting the balloon inflated, better contact now, and we're getting reasonable pictures. As you can see, this is what you see through the normal bronchoscope, which is redundant essentially now. You're looking at the your split screen, so you're looking at the ultrasound findings, looking for your lesion, which you've predetermined on CT scan, which segment, which area, which lobe you're going for. So we'll just fast forward this on a bit, otherwise it does. We'll all fall asleep. So you can see some, there's some contact, isn't it? So as we come down, this is still just ultrasounding again, not looking at your actual vision. And you're coming into the field, you can see distortion already happening. And the difficulty with this, as you'll see in a second, you find your lesion. So you've only got one working channel, so you'll mark yourself, you'll know where you're going, but then your biopsies are blind, so you'll take the probe out, and then you'll go in with your forceps. So there's no absolute confirmation that you're in the right area when you take the actual biopsy. Well, he says it goes on a bit longer than I thought. So once you're happy where you are, you're orientated yourself, it's just a simple biopsy. A lot of these will end up being transbronchials as you're pressing further through. So it's endobronchial and transbronchial essentially. Here we go. And you've marked yourself so you know where you're going, and you're just advancing the forceps into the area to take the biopsies. So how good is it? Well, pretty good, but not perfect. And this chap, this group, did a review in 2012 in chest, and don't worry about all this, but this is, sorry, meta-analysis, not a review. These are all the studies they looked at. Again, none of it's totally homogeneous. There's people with different reasons that they're in the studies, etc. But the take-home message is they got to this number as around 70%. So these are unselected groups, and again, they're not all properly matched, but that's sort of the best we've got at the moment. And there is also a difference between diagnosis and detection. So what's been found in a lot of the studies, you can identify the lesion, but actually getting a diagnosis is difficult. So the diagnosis they're achieving at 70%, but the detection rate is more about 80%. So we're looking at how we can improve that gap or bridge that gap to get closer to the detection rate. And one of the things is this guide sheet. So essentially, you'll get to you'll get stuck at some point when the bronchoscope can't go any further, and then you just push out this guide sheath. And the guide sheath is just basically a little tube which it acts as your extended working channel. Okay, and then you pass your probe through there. And the benefit of that is that you can then, when you've found your area, you just leave the guide sheath there, take your probe out, and then you can put your forceps down the guide sheath. So it should be locked in the same position. Again, it's blind, so it can move a bit. Patient coughs, things like that, it's more difficult. Does it give you a better detection? Are choosing the right patient. So bronchus sign, quite important. So obviously, it's fairly common sense really. Obviously, if an airway leads to your lesion, you're going to have a better yield than if it's sort of peripheral to the lesion or proximal to the airway. Sorry. So those are fairly basic things. So that's potentially radial lever. So obviously, if the lesion's bigger, it's easier. Bronchosine, easier. And it does just get more difficult and more tricky as you get further away, so further from the carina, more peripheral. So it's definitely something that's coming on, and I think it's something that we all should be embracing more. So it is viable, and in the UK, EBUS's recommendation for all cancer sites, so either you have it on site or you have access to it, and so radial EBUS is just a step on from that. And so this is navigational bronchoscopy, was the other thing I was going to briefly touch on. And this is electromagnetic navigation bronchoscopy. So this is a bit of a toy, I think, at the moment. Just due to its costs, it's quite expensive. But essentially what you have is your patient. Hopefully he looks a bit more alive than that. And then you've got a board at the back, which you can see them lying on there. That creates an electromagnetic field. And then you have 3 stickers on the chest wall, which essentially give you, it's a sort of localized sat-nav. So essentially you can picture the end of your bronchoscope, which has a transmitter on, anywhere in that field. So you can navigate your bronchoscope using that guidance. And I'll show you a couple of videos of this, which will probably make it a bit clearer. So the good things are that it guides you to the lesion with your pre-planning, and I'll show you that in a second. It is expensive. Each of those probes stickers, transducers are disposable, and they're about £1,000 each. And again, you don't have the absolute confirmation just using this alone. So this is, I think, this is one of the pharmaceutical companies. This is Super Dimension in Reach. This is the lesion you're going for, and these are the nodes you can see. So as you're coming down the trachea, you can, the end of your probe has got a transmitter in, and so essentially you've got a electromagnetic field that will pick this up, and you can guide it directly where you want to go, having pre-planned it on the CT. So you will have virtual CT reconstruction as well. And these are the kind of things you see. So you come down with the bronchoscope as far as you can, you come up, and then you get stuck. Obviously your bronchoscope will not pass any further, so you can now just extend your probe out with this simple sort of device. It's quite easy to drive. It's got a little curve on it, so it's just like a bronchoscope. If you want to go left or right, you just rotate the whole thing, and it will move left, or rotate it the other way, and it will move right. So it's fairly straightforward. And what we do, we find our peripheral lesion by just rotating this again, and as we approach it, you'll get confirmation, and the only confirmation you get is obviously that you're in the right area by your navigation system. So you have a blob on your computer screen, and when you reach that is your target, but you don't have any further confirmation than that. And this is just the sampling techniques, so you lock it in place and you can take some samples. I'll just show you one more video from a similar, and this just shows you a bit more of the screen you'll see. So this is Covidion's version, which is, I think, slightly superior. And what they have is they have a pre-CT, and they'll mark up your lesion. So you have a big blob, will go on that in a minute, and that will turn into a green dot on your screen as you're going down the bronchoscope. And this is what you see. So you're just doing left or right, following the purple trail, going through the bronchus, and they'll show you in cartoon form in a moment. So you have a normal bronchoscopy screen and your virtual screen next to it, and you're literally following the trail. And this just demonstrates how the guide sheath works. So you come out with your probe up to the lesion, and these are just the airways you'll see as you're navigating through on your screen. So it's very straightforward, just rotating And the green area is your target, so that's all you're seeing because it's obviously blind, and your bronchoscope isn't going that far, so you're just seeing computer-generated images to guide. So you get to the lesion, and then, sorry, it's just, so you just, again, yeah, this is the navigation system. It's very straightforward. Anyone who plays any computer games can do this quite easily. And then you can get your samples. They've got, and this is the guide sheet, the working channel. So you leave that in place, anchor that in place, and now you can pass your forceps, your brushes, your needles, or whatever you want through. And this is how you sample the lesions, which will be predominantly a combination of transbronchial and bronchial, endobronchial. So that's just an idea as to what we can do. So virtual navigation bronchoscopy is pretty much the same, except you don't have confirmation of where you are with your probe. You have a complete reconstruction, and you just follow it down. So you've planned your route, and you just follow it down, but you don't actually have any feedback that you're going to be in the right place. It's fairly straightforward to do. You're just following a screen with left and right, so if you can bronchoscope, it's not particularly difficult or challenging to do. And with this, the expense again is all the software, which is extortionately expensive. And then the licensing fees they charge you annually. But these are things that are coming out and I think are probably going to be more readily available in the next 5-10 years. Again, just some evidence to suggest that navigation systems do work. This was in thorax 4 years ago, and the increase in the yield was about 12% they had, which they did randomise. So just coming to sort of summarise what we can do and what we can't do, and where we should be going, I think all of these are important, and we need to choose the right patients for them. Surgery is still, I don't know if you use the gold standard as a term, but is a single rapid way to diagnosis. It gives you enough tissue so you can do whatever molecular testing you want. Your oncologist can't come back and say we need more tissue. Yield is very high. Obviously the problems are the risks of major operations. We know that a lot of our patients, if you take out a lobe or a segment from them, they'll be so breathless that you're going to cause them more problems. We don't know whether it's the right thing to do. In a lot of the slow-growing stuff we see now, you have lots of slow-growing adenocarcinomas. Is taking them out the right thing to do? I don't think anyone really knows. Bronchoscopy. So this is useful in diagnostic reassurance. Get the tissue for pathology. And our yields are not as good as surgery, but they're around 60 to 90%. The problem we do have is still a significant false negative, as we don't have an absolute direct vision way of taking these peripheral biopsies so you can miss them, having thought you've got them. CT guided biopsy, I think we should be doing for smaller nodules, but again, pneumothorax is the risk. And the other option is obviously nothing and just do a few CTs and see how they're going. Depends on your patient choice. Some people find this very difficult to live with. Last few slides just to sort of think about where we're going in the future. These chaps, well I say in the future, this was 2008 in the ERJ. This Japanese group used the ultra-thin bronchoscope, and these are just the two in section. These are the Olympus scopes, and this has a working channel of 1.7 mil, so it's 3.5, so it's much smaller. So common sense would suggest that you can get further out and get a slightly better vision. And these are them on fluoroscopy, just demonstrating how far out they can get. So this is the standard scope. Obviously with a thinner scope you can get out further. So I think there is scope for this. And these are just the Olympus scopes, and just as I'm sure you're aware, your outer diameter is about 5, but the new ones they're doing now are 2.8. So I think when we do interventional, most of the interventional stuff I use a 3mm channel, and it's quite a big scope. And I think sometimes bigger isn't always better, especially when we're looking at more peripheral work. So I think there is a role for these smaller scopes. So this is just a brief summary of the evidence out there. This is not complete by any means, but showing essentially the EBUS mini probe, the radial EBUS, does increase your yield. Navigation does work, and they use electromagnetic or virtual bronchoscopy, virtual navigation, they seem to increase your yield significantly. All these p-values were really quite significant in the studies as well. So in conclusion, who should be doing this on? Well, I think as we spoke right at the beginning of the session this morning with the cases, your patient selection, your pre-test probability is really key, whether we should be following these people up or not. The patients in the higher risk, should we be pushing forward things like surgery earlier on, perhaps? And then in that big group in the middle, we're not sure, putting them through a big operation isn't great, are they high risk? These are the kind of people I think we should be using it on. The EBUS mini probe does seem very scalable, viable. It's a natural progression from EBUS. There's not a lot more kit you need and not a lot more expense. And then navigation, both helpful, but I think at the moment they're still a bit pie in the sky, that they're so expensive and their yields do increase, but not massively. So what would I do? I think for a truly peripheral lesion, so something very plurally based, CT guided biopsy, I think your risk of pneumothorax is small in those. But when you come into the non-peripheral, non-central, so the ones which we can't quite see with a bronchoscope, but you know they're just beyond a centimetre or two beyond where you're going, I think these are the patients we should be doing it in. So I would go for the radial EBUS with a guide sheath. If I can afford it, I try and get the navigation, and I think the ultra-thin scopes are definitely on the way in. So those are the things that I think we're going to be doing in the future. So thank you very much for your time.
Any questions?
We are speechless.
Speechless.
The
Or hungover, which one?
virtual navigation is a CT reconstruction of the bronchial tree.
Yeah, so the CT, the virtual navigation, not the electromagnetic. So they both use it. They both do CT reconstruction in 3 dimensions. Yeah, so you do need very good quality CT scan to start with, and so sometimes you may even need to do a repeat scan.
The exactly coordinates of the nodule.
Yeah, so you get your virtual CT, and then essentially you're just bronchoscoping down there, so you're looking, but after a while it's just following the pink trails through the bronchial tree wherever it takes you, so you're going left, right, up, down, because you obviously as soon as you get out to beyond where your bronchoscope can go to the smaller subsegmental divisions, you're using a probe which you've got no vision on, so you're just following the line on the virtual bronchoscopy. It's good fun, but it's quite expensive. Yeah.
How much is paid?
So at the moment they charge in the region of about £200,000 for the software package, but the upkeep, the licensing fee varies a lot. So some of them charge hundreds of thousands a year just to license it. So I think it's not as simple as you just buy the software, but I'm hopeful in time there'll be more packages out there, more availability, and the price will come down. All these things, EBUS was extortionate when it first came out, but that's becoming more competitive and being spread out to a variety of places.
Could you comment about your training in this industry?
Okay.
Yes.
How
long it takes?
So I'm by no means am I totally proficient in all of these. I've had some exposure, some training at training centres, but I think it's very difficult to get the caseload exposure. My interventional experience has come through where I work at the moment, which is Eastbourne, which is a very small, sleepy place on the south coast of England, with any surgeons at least 2 hours away. And we've built up the department through using tertiary referral input. I've done sort of fellowships in interventional bronchoscopy, and I think we have a case mix between my other colleagues there, or a skills mix, sorry. So they have interest in various things, and I have interest in. sort of populate each other's skill sets by that. But I think getting the caseloads is very difficult. You need to really do a fellowship somewhere in a big centre that does these, and then bring it out to a smaller centre. Yeah, I think any of these things, when are you competent, is a good question. And I think the BTS are going to be bringing out guidelines next year on basic bronchoscopy. But I don't think there's any real guidance, and it's going to be dependent on your centre. So if your centre does, so for St Thomas's, one of our big centres in London, they do EBUS 7 days a week, all day. Yeah, so morning and afternoon every day. So if you go and work there, you'll get competent very quickly. If you go to a smaller centre where they do once a week list, I think you're going to need to be there, 6 months a year probably, to get your competencies. And I think it's also realising your limitations. So when you start with EBUS, for example, you take the hilar nodes on and the subcarinal nodes. Then as you progress from that, then you take the more difficult nodal groups. So I think you have to also work within your own competency and your own limitations and have some sort of self-awareness. But yeah, I think getting the competency in these is difficult.
Following on that question, so how important do you think is for training this eye-hand coordination? Do you need special, you need to have talent, or do you
PlayStation 3 is probably I think it's good. Grand Theft Auto or something like that. No, I think there is definitely, I say it slightly jokingly, but
that's not a joke.
The boys who come are registrars. Yeah, our registrars who come, the ones who've played a lot of video games, perhaps too much. I don't know what this is doing. This blow up or something. The ones who've played video games are just better. I'm not saying everyone should play video games, but there's definitely a link there. It does all that. The games now are so sophisticated that, to steal a car, Grand Theft Auto is more difficult than a bronchoscopy. So yeah, I think it is very complex now.
This needs to be studied and standardized.
I think there are some.
I'm actually I'm interested in this because we do training with procedures. So any interventional procedure requires a bit of eye-hand coordination. Yeah. And if you do a search, there is this the concept of gamification. So the use of games to practice or improve a particular skill, and in this case, the skill of doing things without looking at what you do. So you look at the screen and you do a procedure. And computer games is one thing. From the literature, apparently playing sports like tennis, yes, where the ball comes and you don't, when you hit the ball, you don't actually look at the ball. And apparently, interestingly, another thing is remote controlled toys. Yes, so being able to drive a remote controlled toy may actually train you, develop some skills in again, eye-hand coordination. Flying a drone will teach you to do better bronchoscopies. But we'll do that next year.
Yeah. Is that your way of asking for the Christmas presents, Jim?
Any other questions? If there are no other questions, we have 5 minutes.